My name is Dr. Carson Smith. I'm an assistant professor in the Department of Kinesiology in the School of Public Health. And I'm going to be leading our panel. We have 4 distinguished speakers, well, at least 3 anyway. I'll be leading us off, and we're going to be focusing on a topic related to physical activity. And believe me, pharmaceutical companies wish they could put what physical activity can do into a pill, but they have not been able to. So we're going to talk about some of the benefits and some of the effects of physical activity on chronic disease prevention. And we have different perspectives. I'm going to talk a little bit about the brain and brain health, and we're going to work our way down from the brain and into the body in chronic diseases that affect mind and body. So Dr. Rich Macko will be speaking second, and then Dr. Alice Ryan will be speaking third, and we'll be ending with Dr. James Hagberg. So just to provide a backdrop for our session today, I'm going to show you some age distributions. This is a demographic of the United States in 1955 and what the different ages were. So men on the left and women on the right, and then the different age categories working our way up to the 85 plus range. So I want you to see this in contrast to 2005. So in 1955, 2005. So you can see that this bulge of little ones in 1955 just kind of moves right on up the chart into the 21st century. And this is a problem that we're dealing with, not only for the numbers of these individuals, but also for the chronic disease conditions that they have. So this is an indicator of the leading causes of death on the left, but then translated into actual cause of death on the right. So you can see that heart disease, cancer, and stroke lead the way as far as causes of death on autopsy in the United States. But if we look at actual causes of death, tobacco use and physical inactivity and diet are also at the top of the list. So our behaviors and what we do have a huge impact on the things that may kill us in the end. So we're going to be talking a little bit about, I'll be talking about Alzheimer's disease today. Alzheimer's disease is on the list as a leading cause of death, but also relevant today are diabetes, stroke. We'll be talking about heart disease as well. Physical activity, in fact, you could argue, affects every one of these leading causes of death. It's known to be protective for some cancers. Obviously, unintentional injuries. If you are at risk for falls, physical activity will help in that regard as well. Certainly can affect our immune system, et cetera. So physical activity really affects many, many chronic disease conditions that can lead to mortality. So that's my opening remark about how all of this ties us together. And now I'm going to talk a little bit more about exercise and brain health. So Alzheimer's disease is a progressive neurological disorder that results in a significant amount of neurodegeneration and atrophy of the brain. So on this image, which is from the Alzheimer's Association, you can see on the left, this is what a healthy human brain would look like. And on the right half of this is what an Alzheimer's disease brain looks like on autopsy. So just a couple of things to point out to you. You can see the very enlarged ventricles compared to the healthy brain, and also the thinning of the cortex. So this outer layer of the cortex is much thicker in the healthy human than in the Alzheimer's patient. So there's a thinning of the cortical layer. And then here, there's this gaping hole where in the medial temporal lobe where the hippocampus used to be and has atrophied. The hippocampus is a critical structure for all human learning and memory, and it's attacked early in Alzheimer's disease. The hippocampus is also one location where exercise has neurogenic effects and may help to preserve the volume of this structure. Now, Alzheimer's disease is particularly, well, people who carry a certain genetic marker called the ApoE, the apolipoprotein E epsilon 4 allele, are at particularly increased risk for Alzheimer's disease. It's not a guarantee that you're going to get the disease, but it's a risk factor also, not only for Alzheimer's disease, but also for cardiovascular disease. And these cartoons on the right here just show what a cell might look like where amyloid plaques have accumulated that are disrupting neural transmission and eventually leading to that cell to die and for dendritic connections to be lost. So in my lab, and what Dr. Macko and I have been pursuing together is whether or not exercise training can be used to prevent or treat Alzheimer's disease before it actually appears in people who are at increased risk. And they may be at risk for metabolic reasons as well. So we do know from much of the research that's been done in healthy people that in healthy older adults that physical activity and fitness prevent age-related declines in brain tissue volume and cognitive function. So you wouldn't want to do this without a spotter, but we do think that exercise training does help to maintain cognitive function and brain volume. Most of this work has been done in healthy older adults, and we don't know as much as we need to about older adults who are at increased risk. So what we do know is that if we ask people how physically active they are, and we classify them as either being low in their physical activity or high, and when I say high, I really mean that they're engaging in what we recommend would be a normal level of physical activity, we can look at their cognitive trajectory over 18 months. And it differs based on their risk status. So if they carry the E4 allele, and they also report very little physical activity, they're at much greater risk for showing cognitive decline over 18 months. So these same individuals that carry this risk allele can reduce their risk to be like their non-allele carrying counterparts if they engage in normal levels of physical activity. So we're showing that there is a gene and behavior interaction that can occur. In these same individuals, we also can track their hippocampal volume over 18 months. And what these findings show, and now I've switched the order of the groups now, so the high-risk groups here on the right, when we follow these individuals over 18 months, and by the way, these individuals were all cognitively normal and had the same volume of their hippocampi at the baseline, but when we follow them over 18 months, we show that those who carry the risk allele and are not physically active show a decrease of about 3% in their hippocampal volume over 18 months. That's a huge loss in hippocampal volume. 3% represents, thousands of neural connections. Those who are physically active, though, and carry this risk allele have moderated their loss of hippocampal volume, actually, and they look more like, again, their non-allele carrying counterparts. So what we really want to know is what happens with exercise training, and what we've done is we've used fMRI, functional magnetic resonance imaging, to track brain function during memory recall in MCI patients. So these are individuals who are in the early stages of Alzheimer's disease, and what we see is that from before to after the intervention, these images are just showing you the two different groups, pre and post exercise training, a 12-week walking program. What we see is that there's a decrease in the activation. So you can see those red and blue blobs on the brain essentially are reduced in size, showing less activation of the brain to do a memory task. And so we have a standardized memory task that they perform before and after the intervention. And what we find is that there's a reduction in the neural resources required to perform the memory recollection, suggesting an improvement in the efficiency of the brain. So this implies that moderate intensity exercise may help to stabilize the rate of cognitive decline and perhaps help older adults who are at increased genetic risk for Alzheimer's disease, that the moderate intensity exercise may help to improve the efficiency of memory networks. But yet unknown, and what we're working on is whether or not exercise training would lead to a reduced rate of progression to Alzheimer's disease from these high-risk states. So that's my talk, and I'm going to leave it now to Dr. Macko to continue our session. You may ask questions, of course, but we will have time for questions at the end as well. So thank you very much. You can raise your hand at the end of the talks if you have some questions.
It's probably hard to believe that's my outline, but it's true. And I want to apologize ahead of time for dressing up as the man in black. But it is thinning, and my wife says that I look ridiculous in heels. Now that I've caught all of your attention, you probably recognize that I'm a neurologist. Does this have a laser? The laser's not working. I'm a neurologist, and I'm the only physician out of this group of people. And there is, I'll use my own pointer. This is my pointer. There's a reason for that. The graduates from this School of Public Health have taught me about exercise science, the effect that it's had on the metabolism in the brain, since I was a little neurologist in 1993, when I did not know what insulin resistance and VO2 max was, when I was studying blood clotting, and when I talked about the effects of TPA and PI and activated protein C, people would shun me at parties and leave and go back to the punch bowl. And they taught me about exercise science, and I began to study that as a risk factor model for how we could prevent strokes in people with cerebral vascular disease. So I sort of owe my entire career to the University of Maryland's School of Public Health, including Jim Hagberg and Alice Ryan, and now some of the new directions I'm going in with Carson. So my hat's off to all of you, and it's wonderful to be the only neurologist that's trying to help this brain that's crying out for brain attack. And you see this person down here at the bottom, that's not Michael J. Fox, that's Carson Smith. And he's teaching me about Alzheimer's disease, and that's actually me. And he's teaching me that Alzheimer's disease needs to be approached early, because once you're older and you have Alzheimer's disease, the cows are out of the barn, the cat's out of the bag. But if you have cerebral vascular disease, it's a horrible bedfellow. It makes the clinical dementia much worse. So we're pairing up together to see what we can do to try and help brain health as a couple. So with that prelude, I'm going to move on and say that imagine that there is a war on U.S. soil, okay? There are 140,000 fatalities per year. And out of that, there are 800,000 brain injuries. But that's just the tip of the iceberg, because 9 out of the 10 brain injuries are silent. So there's 8 million brain injuries a year. That's huge. That's how many are going on right now as I'm talking with you. They're almost continuous. And the numbers are going to double by 2040. Now, let's scale that up a little bit. As we age, the entire rest of the world, except for the continent of Africa, is also aging, such that we're going from 11 or 12% to 21 or 22% older than 65 by 2030, 2040. And the continent of Africa has a relative aging, and so they're starting to experience the same sort of obesity, diabetes, cardiovascular disease in spades, just like we're experiencing now, such that in emerging economies, stroke, and diabetes and atherosclerotic disease is emerging as the leading cause of death and disability. Stroke is the #2 cause of death in the world right now. So there are 15 million strokes in the United States, and that will probably double by 2040. It's a huge, huge problem. So 75% have residual deficits that persistently impair function, and the total cost in the United States is going to be $2.2 trillion. So does that ring a bell? Is that something similar to what we paid for the cost on terrorism? Yeah, this war is being fought in our own soil right now. So let's look out on this audience and say, how many of you have a person in your family or a friend that's been touched by cerebral vascular disease? That's a pretty big number. So, you know, we have a lot in common. My grandmother at 87 or 88 was sitting and watching television, and my grandfather looked over and said, "How you doing?" And she said, "I'm fine." And then she curled her arms up. And that's, for some of you that recognize, that's decorticate posture. That's from a brainstem stroke. And then she coded in the scanner. It's a good way to go out. She went out quickly, but she had a brainstem stroke. So, you know, it happens to many, many, many people. But the vast majority of them live about 7 or 8 years, and we all think it's a cerebrovascular event, and then they just have hemiparesis and they walk around. Not true. Medicare beneficiary database says that out of those people that are initially not demented, that 10 or 11% by year 1, 17% by year 2, 22% by year 3 are demented. It is a progressive neurodegenerative disorder because you just keep picking off pieces of brain like grains of sand when you're older and you have cerebrovascular disease. And it does definitely interact with Alzheimer's disease to increase the clinical dementia. So, are we managing it wrong? This is the big question. What does conventional stroke rehabilitation do? And here I am, I'm the clinician. I'm putting myself up in front of all of you like you have little mental squirt guns or dart guns that you can shoot at me, and you're going to ask me questions about how we handle the policy of management. Conventional stroke rehabilitation usually ends within months, right? Okay, you can read about the Medicare rules. You can read about how Blue Cross Blue Shield does it. You can find out how the policies run in different countries. And you'll find out that people end their care within 3 to 6 months. Alice, isn't that correct? And does anybody know of any countries in which that's different? Please tell me if you do. So the problem is chronic disease management. Fitness levels are 1/2 of normal. The energy rates to walk are twice normal because these people are biomechanically abnormal in terms of their walking. 9 out of 10 strokes are silent. Dementia rates are 10-fold higher. They have impaired glucose tolerance or diabetes in 75 to 80%. Why? Because as soon as you have a stroke, it's not all in your head. You change the neural pattern to your muscles, and you switch from slow twitch, which is your typical anti-gravity, because you got to sustain that activity for a long time, to fast twitch muscle. That's the default muscle type, probably because you have to escape predators. But whatever that neural innervation pattern is, it becomes fast twitch, which loses oxidative capacity, and it loses the ability to take up glucose in response to insulin, and it's contraction-dependent glucose uptake. So what happens? You become diabetic, and you become anaerobic. And so every time you walk around, you pulse yourself with oxidative injury, which creates free radicals, and your body becomes more diabetic. And so you accelerate this cellular injury model. It's just a cell cycle, oxidative injury cellular senescence model. And 97% of people have suboptimal stroke risk factor management. Where is that? It's in Baltimore. We're the third world country. These are people that come into us, and I drop my glasses. Thank you. I get impassioned sometimes, and things fall out. So, I mean, if somebody put this up in front of a congressional board, I mean, heads would roll. Somebody would lose their job, probably a federal employee, probably me, because that's my job, but I don't want to talk about that anymore. We should shift and change to the next slide. So what could we do? So we goofed when we designed how to take care of stroke. We decided that we're going to judge all the care based on the profile of recovery. And we forgot that motor learning and exercise, people could respond to that for long periods of time afterward. But we blew it. We just focused on the first few months. So we decided to test this model. We call it task-oriented training. It doesn't matter what you call it. It's semantics, where you combine motor learning with exercise to kill more than one physiological target endpoints. And we ask some basic questions. Can you restore fitness? Can you reverse diabetes or the pre-diabetic state? Because those things poison the vascular system, the brain. Can you improve walking or balance years after a stroke? Does it make a difference to people and their function? Can we change cognitive function? Can we improve brain blood flow, which could potentially help reverse or reduce the chance for another stroke? So I'm going to give you a little bit of a meta-analysis just from our work from University of Maryland that forms the basis for the P01 that Carson and some other folks from College Park and engineering and from the School of Public Health are working on. First of all, our high-intensity exercise program can restore 30 to 40% of the fitness that's lost after stroke. And if you look at the requirements for activity of daily living mobility skills, it adds enough that you can actually do mobility skills without going into the lactic acid zone, without getting that fatigue burn. And it also raises the VO2 by up to 5 milliliters per kilogram per minute, which, according to the European Heart Journal, should reduce the chance of cardiac death. And since we don't want people to die, that could be considered a good outcome too. So next slide over, you see the reduction in the glucose area. We reverse IGT and diabetes classification based on the 2-hour oral glucose tolerance in 58% of people, which got the attention of the CDC and the Italian government, which is using this in part of their socialized medicine system because this has public health implications. It increases walking speed. Why does it do that? This is correlated directly with an increase in activity in the midbrain and the cerebellum. Why is this interesting? Because those sections of the brain are below the level of human strokes. So if you turn on those areas which are below the level of they're in the cerebellar area, the back section of the brain, below the level of the middle cerebral artery, that means they're below the level of most human strokes. So that network is still available to turn on years after a stroke has occurred. So that gives hope that the brain neuroanatomy for walking can be woken up. So finally, I want to end with my Steinbeck slide of mice and men. In mice, exercise after stroke can turn on neurogenesis. Probably it does that by activating, Carson would say, brain-derived neurotrophic factors. Carson, can you say that? Can you say brain-derived neurotrophic factors?
You're doing a great job.
Okay, so Carson can say brain-derived neurotrophic factors, which we recently showed are 1/4 of normal in the hemiparetic leg muscle and half of normal in the non-paretic leg muscle compared to normal, which means that we may be depleting the fertilizer in the skeletal muscle that waters the brain. But it appears that we can increase brain blood flow and probably cognitive function, at least in the non-affected hand, to improve non-affected hand motor learning with exercise, low-intensity aerobic exercise, in older people that have had a stroke by doing leg exercise. This suggests a generalized cognitive benefit. And this gives us some hope that we may be able to maybe give some benefit to the brain of these older people that are going down a road of dementia. And we are setting these up in community-based centers. There's one in Cambridge at a strip mall. There are 3 running in Youngstown. I speak there Thursday and Friday this week. And they want to set them up in YMCAs. So they're spreading out. We have one in Kingston, Jamaica, University of West Indies, that's going in on a grant with us. People go home after a stroke. They go home. There's no rehabilitation. It breaks my heart out there, which is the case for most places in the world. So our job is to empower all stroke survivors to fight back against the disability, improve their heart and brain health with structured exercise. And there's a lot more research to be done, and I intend to do that with the School of Public Health and Engineering. And thank you all for your attention.
Yes, so there's no chance I can follow that, Rich. Thanks very much. You should have gone last. Anyway, I'm going to focus a little bit about physical activity and weight loss in the prevention of inflammation and obesity. And just to bring you up to speed to the very latest of the CDC maps of the prevalence of obesity. So they look at BMI of greater than 30. But the CDC started this in 1990. And the map then was blue. We don't even have blue on the map anymore. And blue meant less than 14% of the country was considered obese. And now in 2012, you can see that none of the states have less than 20% that are considered obese. And the majority have between 25 and 30. And quite a few between 30 and 35%. So really the weight of the nation is upon us, and really one of the quotes is, to win, we have to lose. And then the media has really taken on quite a bit of what's the importance of fat and when fat attacks, and how is the fat cell waging war against health. And that dieting may not be a magic bullet, and maybe that's where physical activity comes in with diet. And then Time has also looked at the role of inflammation and saying it's the silent killer, and that it links inflammation with heart attacks, cancer, Alzheimer's, and a variety of other diseases. And so really, how do we look at inflammation? You can look at it in the blood. And so there's pro-inflammatory cytokines, the interleukins, TNF-alpha, tumor necrosis factor alpha. The liver has the acute phase reactant proteins, SAA and CRP. And the endothelium has the adhesion molecules. And so they're circulating in the blood. And what's the importance of these plasma measures of inflammation? So the Health ABC study is a large cohort study of over 3,000 individuals over the age of 70, I believe. And they've shown that inflammation is associated with everything, you name it: cancer, coronary heart disease, congestive heart failure, diabetes, cognitive decline and stroke, diabetes. And so it's not just shown in Health ABC. There's a number of cohort studies that's shown that the increase in inflammation is associated with coronary heart disease and stroke. And so what's the importance of that? Inflammation is associated with physical function and disability. So there are a variety of studies that have shown that if you increase inflammation, it's associated with a loss of muscle, strength, decreased walking speed, a slower chair rise, and stair climb performance. And in effect, if you look at some of these cytokines like IL-6 and some of the receptors, TNF-alpha, receptor 1, they predict the onset of physical disability. And this is independent of comorbidity. So it's really, inflammation is, and it ties in well with physical inactivity. So it may be a common pathway for this age-related loss of physical function. And this may be independent of whether it's initiated by an acute event, chronic disease, or aging itself. So then we ask, can we modify inflammation? Can we do it with diet, and can we do it with exercise training? And so I'm just going to share with you just one study, and there's a lot of studies out there, but this is just one study that we actually ended up doing with postmenopausal women that participated in 6 months of weight loss, or alone, or combined with aerobic exercise that they did 3 times a week in our gym. And we just looked at plasma markers of inflammation, and you can see the blue is diet and the red is diet plus exercise, and the dramatic decrease in these cytokines in the plasma after exercise compared to diet. Now, this has been confirmed and published again, and really weight loss is important, so we can't disregard that, but exercise does have its benefits. And then this was the only study I could find where they've looked at inflammation over a cohort. So they followed these people for 10 years and looked at the association. If you look at the left, you can see, I'm not sure you can see it, but that's, I think it's T, now I need my glasses. It's a CRP on the top and IL-6 on the bottom. And you can see at baseline, so the dotted line is those who participate in physical activity, and those who don't is the solid line. And so at baseline, those who participate in physical activity have lower levels of CRP and IL-6. But then when you look at the follow-up, they look to see after 10 years that those participants who rarely, they compared them those who rarely adhered to physical activity guidelines to those who did, and the high adherence group just had lower levels of CRP and IL-6. And this is even after you adjust for several factors like age, sex, and BMI. So if we can look at inflammation in the blood, but we also look at inflammation in the adipose tissue. So we actually take adipose tissue biopsies from the subcutaneous abdominal cavity and also in the gluteal tissue, and then we go into the lab and we look at the release of the cytokines. So one of the questions you can ask is adipose tissue cytokine production higher in obesity, and then can we change it with weight loss and exercise? So this is a study by Phil Kern, who looked at the adipose tissue cytokine production in obesity. And you can see they have plasma levels of IL-6 on the top left bar, and it's the IL-6 secretion on the bottom. And across BMI on the x-axis, you can see that higher levels of BMI, there's an increased secretion of either IL-6 or TNF-alpha. And is that important? So this is another study where you can see that higher levels of both insulin, glucose, plasma TGs, and cholesterol are associated with this, the transcripts, so TNF mRNA levels, and across all of these you can see so the importance of not only in the plasma but in the adipose tissue where the cytokines are being produced, that it's increasing your risk. And this may be the link with all these chronic diseases. We are currently looking to see whether exercise with and without weight loss is changing the adipose tissue cytokine secretion. And our results are looking pretty promising. Adiponectin, which is an insulin sensitizing hormone, is increasing. And so that's only with exercise and not with diet alone. So just to summarize, that weight loss and exercise training can have a direct effect on the innate immune system, as well as a direct effect on the adipose tissue. So it can affect the PBMCs to decrease the production of pro-inflammatory cytokines. And in the adipose tissue, we can decrease the production of these pro-inflammatory mediators, and then the anti ones, which I haven't really mentioned, which is like IL-10 and IL-1 receptor. And it can also affect the liver, so we can have decreased production of CRP and SAA, leading to a decrease in the blood concentrations of these inflammatory markers and a decrease in the inflammatory state. Now, you can look at inflammation in the adipose tissue, but we also look at it in the skeletal muscles. So we've looked at it in the stroke participants that we've had in the vastus lateralis muscle in both the paretic and the non-paretic leg. So the paretic leg shows an increased level of this TNF-alpha, and we think that may mediate the increased risk for diabetes. And so we're testing now in a large grant whether we can modify that with treadmill training. And so we do this bench to bedside research, but really the bottom line is exercise is the best medicine. So I don't know if we want that pill, Carson. This pharmacist wants this gentleman to just jump, and really let's hope we can use this tool to improve our health. Thanks.
Thanks for getting me up to speed.
Yep.
Okay, I guess then I'm the cleanup hitter, right, or something like that? However that works. Is it there somewhere? Yeah, there it is. So yeah, this is me. Okay. So here in the School of Public Health, I'm in the Department of Kinesiology. And I'll sit here and look right at my dean and say, there's not a whole lot of kinesiology departments in schools of public health. So here's, to kind of ground us, what's the definition of public health? Refers to all organized measures to prevent disease, promote health, prolong life among the population as a whole. Okay, so let's keep that as kind of our groundwork to start things off. So should physical activity be part of public health? Well, in case you've been asleep for the last 50 years, the latest survey of the literature, I think this was a review generated by Frank Booth at Missouri, one of our most strident and vociferous speakers on the benefits of physical activity, indicates that the lack of physical activity causes 37 unhealthy conditions. Here's among the 37. Nothing on there that we want anywhere close to us, I think we would all agree, right? And remember, remember down at the end it says et cetera. That's not the whole 37, okay? There's a bunch of others included in that list. So is physical activity important? Yeah, I think so. So if you don't already know it, physical activity is clearly a critical aspect of public health. So here's one demonstration of it, and I think this one brings up the point about physical activity. Alice and Rich and Carson to some extent talked about exercise training, which is a little different than just getting physical activity. I was talking to, I don't know, can't see if I see Dina. Yeah, she's sitting in the back. She said she got a little bit of her physical activity from walking from the School of Public Health over here and back. Okay, that's not exercise training, but it's physical activity. It's getting up and moving around. So these are some classic data from Steve Blair at the Aerobic Center. Whole population of men and women, I think there's about 10,000 men, about 3,000 women, categorizing them based on their fitness levels. As my undergraduate class categorizes group 1 there on the men, they're the low fit group. So they're the lowest 20% of fitness of kind of a mixed population of about an age of 50. So the best, I always ask them, what name would you give to that group? And the best one that they've come up with so far is ultimate couch potatoes. And I'd have to kind of agree with that. They're beyond couch potatoes. They're ultimate couch potatoes. So here's, on the right-hand side, there's the relative risk of dying. So obviously, as a man or woman, you don't want to be an ultimate couch potato. But if you want to get a benefit, if you do happen to be in that group, if you want to get a benefit, how much physical activity do you have to get? A little or a lot? A little. All you have to do is get, I was going to say butt, but in our family we use the word bum. You have to get your bum out of the lowest 20th percentile to the next 20th percentile. You can still be below average in terms of fitness, but risk goes from 3.44 down to 1.37 in men, from 4.6 down to 2.4 in women. A huge reduction in risk with a minimal amount of physical activity. Here's some data from Ralph Paffenbarger, same type of thing. He has a questionnaire. He doesn't assess fitness. He assesses energy expenditure during physical activity or exercise and compares, so the relative risk of dying is 1.0 in the comparison group there in this Harvard alumni that gets less than 500 kilocalories of energy expenditure a week. And folks, it's really hard. It's really hard to get that little physical activity. You have to really work seriously at it to get down in that group because they include just about anything as physical activity. I mean, probably my waving my arms up here would be part of physical activity and would get me out of that category. But again, relative risk of dying, as you go down there, if you get a fair amount of exercise, more than 3,500 calories a week, risk drops by, almost a half out there. But again, how much exercise do you need to get? How much physical activity do you need to get a fair reduction in risk of dying? A little or a lot? A little again. Just get out of that lower group and you've reduced your risk by 22%. The difference between 1.0 and 0.78. A little higher, your risk is down 27%. A little higher, risk is down 37%. What's a scientist without a graph of a few of his data along the way? I don't think there's any mystery whatsoever with the diabetes epidemic in the United States. These are some data from our lab a number of years ago now. This is a small number of men, cardiac rehab patients. If you do oral glucose tolerance test, Rich and Alice will be able to interpret these instantaneously, but that top line is before training. We want to keep glucoses during that glucose tolerance test less than 200. They're up at about 270. So they've got big-time, full-blown type 2 diabetes. 12 months of exercise training. Now, by the end of this program, they were exercising 5 days a week. They had lost about 10 pounds. But how did their glucoses look after that year? Yep, if you send those responses to an endocrinologist, they'll say, you know, you're in your mid-60s, you got a peak glucose of 180, keep it there for the rest of your life and you'll be great. But again, this is exercise training. Okay, this is more than just physical activity, but it does show that with that high amount of physical activity, that high amount of exercise training, you can reverse type 2 diabetes. Then we went the other direction. Instead of doing a year of training, we did 7 days of training. 45 minutes, 7 consecutive days at about 70% of VO2 max. There's their diabetes beforehand. Their glucose is up around 255-ish or so. 7 days of exercise, no weight loss. Okay, this is not because they lost weight, because their weight was maintained the same. Do they still have diabetes? Yes, on average, they're at like 208 instead of 200. But are they a whole lot better off than they were 7 days ago? Not 7 months, not 7 years, 7 days ago. So folks, I really don't think that there's a huge mystery in what's going on with the diabetes epidemic in the United States. You know, Rich's patients with stroke who can't exercise. There it is. Same type of thing magnified here. So I very firmly believe the only way that for the public to be healthy is for them to be physically active. And here's part of our problem. You know, people are into counting daily steps. Well, if they had those little step counters back in the Paleolithic times, they would have had to have had a few extra digits on the readout probably, because they're up to 10 to 20,000. A whole bunch of studies in the 60s up to 2007, huge drop. Colorado 2002, bigger drop. U.S. adults 2010, even bigger drop. Amish, I think these were the Amish in Ohio, 16,500. What's the prevalence of diabetes, obesity, heart disease in the Amish? Not so much. Why? 16,500. What's that? Oh, stroke patients are 2,000 steps. Sorry, I didn't interpret that very quickly. Yeah, stroke patients, 2,000 steps. Where are they set up for all these other problems along the way? So across that same time span, most evidence indicates that caloric intake has actually been decreasing. Okay, so physical activity is going down, which is a bad thing. Caloric intake is going down, which is a good thing. Should be. But substantially more schools of public health in the United States focus on nutrition rather than physical activity. I don't think that's a good idea, but I'll reserve that till later. So, remember, if you've ever sold a house, what are those 3 magic words from a realtor? Location, location, location. Well, I've twisted them a little bit. In science, we're looking for our niche, our niche, our niche, you know, our focus that we can be the best at. Well, here's our focus that I think we can be the best at. You'll notice some names on here. There are some missing. I 100% know that. But these are faculty here at the University of Maryland, College Park, and those at Baltimore. So if we're talking about the brain, we've got Rich Macko, Brad Hatfield, and Carson Smith. If we're talking about the heart and cardiovascular risk factors, myself, Steve Pryor up at Baltimore. If we're talking about the adipose tissue, Andy Goldberg, Alice Ryan here. If we're talking about hip fractures and Physical activity, J Magaziner, if we're talking about muscle, there's a number of people here in College Park and at Baltimore. And again, there are more that should be added on to my little anatomical drawing here. So I guess my point is, what suits you better? And again, it's not exercise training. It's not going out to do a 4-minute mile. It's being physically active for that 30 minutes a day. If you ever get a chance, I think it's still posted out there. There's a whiteboard, like a TED Talk on, what's the title of it? It's 23 and a half hours. Yeah, 23 and a half hours. It's amazing. If you ever get a chance to go out on the web and track it down, I think it's a YouTube video or something like that. Talks about that half hour in terms of what do you do in the other 23 and a half hours. So that's my pitch, and I'm done.
All right, so we have just a few minutes left. I'd like to invite the speakers to come up to the front, and I'd like to present an opportunity for you all to ask any questions you'd like to follow up with any of the talks.
My question is actually for Dr. Ryan about inflammation in adipose tissue. Sure. I've seen some articles lately focusing on high levels of visceral fat, even if people aren't obese or clinically obese. Do those still carry the same risk factors for inflammation? Is it just really the fat or fat amounts?
No, it's both. And clearly there's an association of higher visceral adipose tissue and heart disease. We actually don't look at it in stroke yet, but we can't get at the visceral tissue to see what the inflammation levels. There are some studies that have done bypass surgery, so they'll get some, and even in those studies, there's higher inflammation in that visceral tissue.
There is in visceral compared to other depots?
Is it higher than other depots? No, it's just high in there. Yeah, higher in obesity.
Go for it.
My question is, the message that exercise is valuable and protective and everything is been out for a long time, and we've all heard it. But yet, why is it hard to get people to do that? Why is it hard to get people to exercise? I speak from, I'm a runner, and I love running. I love exercising. My wife is the other end of the spectrum. She hates to exercise. She won't exercise. She has diabetes, heart disease, and yet she, like a lot of people, you can't get her to exercise.
I think one of the main problems is that people don't understand that physical activity has a huge impact as opposed to exercise training. I mean, I'm not about to insert myself into your marital situation. I have exactly the same situation. Okay, I'm not a runner, but active, and my wife doesn't do a whole lot. But she may see you going out for a run and coming back tired and all sweaty and say, I don't want to go there. Yeah. Which is, you don't have to. Get out there and go for a walk. Find a nice park. Will that turn things around immediately? No. But in the long run, will it have some pretty dramatic effects? Yes, I think so. So I think there's that misconception that it takes running like a 4-minute miler and finishing your workout with your hands on your knees, huffing and puffing, when in fact you can make it very enjoyable and have a nice walk. Some strategy, buy everybody a dog.
I just want to admit that my days of a 4-minute mile are long since past. I know you can all tell that from a distance, but I saw a patient yesterday that was a neuromuscular patient that was pre-diabetic and had a pre-diabetic neuropathy. And I told them that, at your age, you can reduce your chance of going on to diabetes by 77%, or 70% versus about 11% if you lose 8 or 9 pounds and do an hour and a half or 2 hours, maybe 3 hours of walking, half hour a week. And I set up a bet with her husband. I said, what you need to do is she needs to walk a half hour most days out of the week, and you're going to pay her $5 every time that she walks. And you're going to walk with her at the mall and give her the money and go shopping with her at that time. The concept behind that is that you set it up with a unit, with a socially reinforced unit, and build it into people's lifestyles. It doesn't have anything to do with exercise. It has to do with what's fun for those people and can keep being done because it's free living physical activity, not structured exercise that is burning the calories, and it doesn't have to be even moderate to high level activity that necessarily produces the biologic effects. Now if you look over the decades, what's been happening is it's gone from high to moderately high to moderate to any activity. That's what's been happening over the past 3 to 4 decades in terms of the national recommendations for what produces health benefits to the cardiometabolic system. And I think when you get down to about 1,200 calories a week, you can start to say, okay, you're going to get some bang out of the buck. If you go below that, which is very hard to do, as Jim says, then you're really doing pretty bad. But it's the free living activity, just getting out and moving around, doing gardening, doing something you like. And bets really work good between spouses.
In most cases. In some, the opposite.
I want to make a couple comments. One is in my marriage.
Wait a minute, this is the physical activity group.
So I just want to set the record straight. But secondly, I just want to commend all of you on the work and the partnership between College Park and Baltimore. I'm from the Baltimore campus, Jay Lipscomb, but I think every time I've been here, the more people I meet in kinesiology, the more excited I am about this partnership because of this. And I think we really need to get those that are here today that are interested in social determinants of health and health behavior and kinesiology together and, really make it a dent in the problem in our state. And I think it is.
I think one of the key next steps is related to, how do we get people to do it? I mean, we submit grants to NIH and they say, yeah, you're going to provide us some more evidence that exercise is good. We already know it's good. We don't care that it's gooder. It's already really good. Now get us to figure out how to get people to do it. And I think we have the capacities in the School of Public Health to do it.
Right? I mean, the action and working together with communities to figure out how to do this differently and better. So again, great panel.
Sandra? What?
Is there a difference in terms of health benefits or health outcomes between doing all your exercise all at once or spreading that out over the week?
Yes. No. I mean, the weekend warrior thing is not a good thing. If you go out and run for 3 hours just on a Saturday, that's not a great thing. But if you can space it out, is it magical to get 30 minutes every day? No. If you get 15 minutes one day and 45 minutes the next, it's more the doing it than it is some absolute amount and kind of getting it into your routine along the way. If you can only do a half hour on the weekends, on the weekdays, because you're very busy and you've got a little bit more time on the weekends, then go for it.
I think when you're getting into the zone of overtraining, you got to recognize that the adaptations that occur in the muscle occur during the rest zones. When you're talking about chronic disease in disabled people like stroke patients and older people that are beginning into the exercise, you have to go easy with those folks and give them adequate rest. And when you're talking about the gerontology population, there appears to be a window in which approximately 20, maybe 30 windows, leucine-enriched protein intake definitely reduces the damage to the muscle and increases the amino acid uptake that occurs and the benefits of the exercise. That includes aerobic and resistive. So there's a biological benefits in terms of both the rest and the nutrition timing. But those are sort of special cases. In general, the just get it done. just do it.
So just to add, and then Sandra, just one moment, but just to point out that, a lot of sitting time also has been shown recently to be detrimental So even if you're physically active, but you sit for 6 or 8 hours, I'm sure none of us do that, at a time, then that can also have health effects as well. So get your treadmill desk set up and, okay, Sandra.
Thank you all. Okay, I'm imagining right now, we've talked about the evidence and then translating the evidence into practice and policy. Dr. Satcher talked about that this morning. So imagine the partnership between our clinical colleagues in Baltimore. Within our own school, we have epidemiology, we have family science, behavioral community health, environmental health, everybody. Now, what if we were to join in and say that between now and when the legislative session opens next January, that we develop a plan for what we would propose to the policymakers of the state of Maryland to address this issue? What would you put on the table to them?
My wife is a 5th grade teacher,
I was just going to say,
and
kids, you have to
that's
start
one
with
place I would start. I mean, I'd start with the kids. It's they're already in a controlled environment, and quite frankly, there's all these videos out on the internet. Just a month ago, she went to this site. I don't know what the site is, and I'm not in advertising for it, but they do a lesson, and they have a 2 or 3 minute video where they get up and dance around or sing and whatever, and then they sit down and they go back to their next lesson. She goes, I've written fewer referrals to the principal's office in this month than I have any month of the year. So I think that's an easy place to get started. It's a captive audience. Hopefully it will stay with them. It could have big bang effects down the way, and then you can spill it outwards, involve their parents, etc.
I remember my son is not in the audience now, so I can say something about him. I know he was working on which shoe was the left and the right. So I would not rely on him completely, but one thing I would do is I would incentivize participation in lifestyle modifications using point-of-care therapy, where if people recognize that your medication, if you have a pre-diabetic state or obesity or any element of the metabolic syndrome, your medicines are not enough to keep you from going down a natural history of decline where you're going to get presence of strokes, they're going to be subclinical, where you're going to get vascular disease over time, where you're going to get cumulative problems. And if you don't deal with that with diet and exercise, and you don't need very much of it, you're not participating in your health care by just taking your medicines. That I would incentivize those elements of lifestyle modification and create an interactive agenda using smart devices and a reporting mechanism that they needed to do that. And I would build that into the different levels of care as such that they were in the silver, the gold, the platinum, that they needed to be able to do that, to be able to say that they were taking care of themselves correctly.
Okay, I would just like to thank everyone for being here. We're out of time, so I'm going to close our session, and I'd just like to thank our speakers and all of you for attending. Good afternoon.